bigger than the right because of the mass effect. And sometimes, on the contrary, the affected breast is adherent to the chest wall and the normal breast hanging down a little bit lower. So there is no rule about this. You really just have to observe and document what you see. Then the next step with palpation, it will, or further inspection in other positions, it will tell us about what is exactly happening and what is the problem. So now, other things you may come across is to see a nipple in this position. Okay? Yeah. So if you see something like that, this is definitely abnormal. Okay? So this is called nipple inversion. Okay? Sometimes it looks like a slit. Sometimes it looks like a partial, yeah. So sometimes it is just a partial, like that. So not complete inversion. Sometimes it is just a deviation. Okay? Yeah. Then after this, you need to comment if you see any prominent masses. Like here, maybe there is one, but I'm not sure. Okay? Then after that, ma'am, can I ask you to put your arms above your head? So we will ask her to do this position, both of them. Okay, so what's the idea of doing this? The idea of doing this is two things. Number one is for the breast itself. Number two, for the axilla, to make the axillary areas visible. For the breast itself, it will allow me, if the breast were hanging down, it will allow me to inspect the under breast, okay, so the inferior surface of the breast. Another issue related to the breast itself, sometimes if there is a mass that is adherent to the skin, when the patient puts her arms up, the skin will be pulled in, and that is called skin grooving, or dimpling, or puckering. The three words mean the same thing, where the skin becomes pinched or grooved inside because of the mass that has attached, which is attached to the muscles and to the skin. When the muscles are stretched like that, so it will pull the skin in. So I repeat again, we will see the inferior surface of the breast, then we may see the mass creating or making a grooving or dimpling or puckering. Okay? The other thing now related to the axilla, I can see if there is any axillary lymph nodes are made prominent by exposing both axillary areas, okay, or axillary regions. Then after that, the third inspection position would be to ask the lady to put her hands on the hips, okay, in this position, and ask her to apply some pressure to contract the pectoralis muscles. So we want to tighten. Look how I tighten my pectoral muscle. That's what we would like to do. Okay? Now this may make some masses more visible. Okay? And then after this, I need to do the palpation. So palpation, its better ideal position for palpation should be in supine position. So I'm going to change your position. I will make you flat down. Okay with you? Okay, she says okay. So what we have to do is to get her lying down in this position, and then I'm going to ask her to put hands behind the head. Okay, to put the hands behind the head in this position. So what I will do, she came with a concern about a lump in the right breast. So I start by examining the left breast. Okay, similar to the abdomen, when there is a problem or a pain in here one area, we start away from it. But for the breast, it has a clinical, importance. Number one, I would like to feel the texture and the consistency of the breast, because every lady has a special, let's say, not consistency, it is a kind of a tissue density, okay? Because it depends on the age of the patient, and sometimes even in the same patient herself, during the various periods of the menstrual cycle or various phases, the breast density differs. Like the breast density increases towards the date of the menses. Then after menstruation, the fluids, a lot of fluids is excreted or disappear from the breast congestion, so the breast becomes softer to feel. Okay, and similarly in pregnancy, sometimes there will be another changes like enlargement and the hypertrophy of the breast gland, and during lactation also is another changes. So the same lady has changes, and from one lady to another, even if you take two different females at the same age group, their breast will be different. Okay, the feel of the breast will be different. So I start examining the breast. Now there are different techniques how to examine the breast. One of the techniques described is to go in circles. Okay. The other one is to go into vertical, up and down, and the other one is to go into transverse, horizontally, right and left, or medial lateral. Okay. All of them are correct. The most commonly used one is in circles. Okay. But all of them correct when you actually cover and examine the whole breast. You should not miss any part of the breast. Okay, so that's very important. So we start like from where I'm standing now. I will start from this area. Okay, and I start close to the areola. Okay, then I go wider in this way. Okay, then I go even further. Okay, until I examine this part. Then I must know that every breast has a breast tail, and the breast tail is an extension of breast tissue towards the axilla. So I will examine the area of the breast tissue in breast tail, and then finally I would like to have a gentle feel of the areola with one finger. Okay, especially if the lady has reported to me a nipple discharge. So in order to demonstrate the discharge and see where is the discharge coming from, single nipple, single opening in the nipple, or multiple, and what kind of discharge is coming. Okay, so then I would repeat the same thing, for the affected breast. So I will start here. Now, one of the wrong things that people examine on tips of fingers. This is wrong. The ideal and the correct way, you must examine in the palmar surface of the fingers. Okay, not with the whole hand. Okay, it's enough to use half of the hand, the front half of your hand, this way. Okay, so we start this way. Here. And I keep looking at my patient face, make sure, because this is the affected side, I'm not causing any pain, because what the pain or tenderness is one of the features of the lump that I must elaborate on. So I can feel actually in this mannequin there is multiple lumps. Let's say that there is this lump here which I can feel, and I feel the axillary tail. So I'm going to focus on this lump. Now, this lump is located in the right breast, and the lump is centered, okay, in the right upper quadrant, okay, right upper outer quadrant, because in order to give the location or the site of the lump, we divide the breast into 4 quadrants. So this one is upper outer, this one is lower outer, this one is upper inner, and this one is lower inner. We don't use medial lateral, okay, here, because for bilateral organs it's confusing a little bit, okay? Yeah. So then, more accurately, I should say that the lump is about 2 centimeters away from the nipple. And more additionally, I would say it is at 11 o'clock position. It is at 11 o'clock position. So in this way, anyone who reads my findings will be able to understand and to locate the lump, especially when the lump is small. When the lump is large and the mass is large, involving the whole quadrant, we don't need to give the clock orientation. So clock orientation really helps for the smaller lumps. For the bigger one, the large one, you can say that there is a mass occupying the whole upper outer quadrant. Okay? Of course, I did not mention with inspection what other things you need to look at. You really need to look for any changes in color, any scars. The usual things for the abdomen applies here. Additionally, of course, there is the odorage and skin edema, okay? And if there is any ulcerations, nodules, so these are the things with the inspection. So now I have given the site, then the size is about 1.5 centimeters, 1 to 2 centimeters in size, and the shape is spherical, and the surface is smooth, okay? The edges are, actually the lump looks to me oval in shape because this diameter is slightly bigger than this diameter, okay? The edges are clear, all right? And the consistency is hard, solid and hard. Now, solid is different from hard. The opposite of solid is cystic. So when we say solid, then I have to decide soft or firm or hard. Okay? So it is solid and hard. The temperature is equal to the rest of the breast tissue, and it does not appear to be tender. Okay? Now the lump is, I can pinch the skin over the lump. It's not fixed to the skin, and the lump still mobile horizontally and up and down. Okay? The final thing I need to elaborate on is the axillary examination. Okay? Any questions at this up to this stage? Is it clear? Okay. For axillary examination, I need to examine your armpit now. So can I do that? I need to sit you up again and sit really upright. Okay? So she agrees, and then we have to go. Now, most of the students actually make mistakes in the axillary examination. Okay, listen to me from now. Right axilla is examined in my left hand. Left axilla, I should examine it with my right hand. Okay? So always use the opposite hand. What I will do with the other hand, I will use it to support the arm of the patient. So what I'm going to do, I'm going to put forearm on forearm. So this way. Their forearm on my forearm. Then I will examine the lateral. I will use 2 to 3 fingers. The lateral, which are located on the uppermost medial surface of the arm. This is the arm, the medial surface here, lateral surface here. So it is here. This is the lateral subgroup of the axillary lymph nodes. Can you see?
Yes.
Okay. So this one is the lateral. Then the medial has anterior and posterior. So this is the anterior medial, which we call it also pectoral. Then this is the posterior, which we call it subscapular. So the medial we have anterior and posterior. Then finally the apical lymph nodes. Okay, apical are in the depth of the armpit or in the axilla. Okay, sorry, we say central. The apical are really the deeper part of the lymph node subgroup, which cannot be palpated. So I repeat again: lateral, anterior, posterior, anteromedial, posteromedial, and the central. Central, I need to go from below. Okay, like that. And maybe the posterior also. You may always use the opposite hand. If you try to do the opposite, you will fail. You know, you will not be doing it correctly. So you must do with the opposite hand. All right? Then finally, I would like to examine the supraclavicular and the infraclavicular. So if the clavicle is here, so I will be examining these areas. For breast, we do not do percussion, we do not do auscultation. It is irrelevant steps of the examination. Okay? Then after finishing from the breast and the axilla, there are essential additional examination I must do. I must examine the thorax of the patient, because commonly the patients with advanced breast cancer disease, they might have pleural effusion or pleural metastasis or lung metastasis. Another thing is to examine the abdomen. Of course, she has to be in supine position to check for presence of hepatomegaly and to check for presence of free fluids in the abdomen. Okay? The other thing is, if she has a bone pain, I try to palpate this bony, painful area that she has the pain, especially the tips of the spinous processes of the spine, okay, or any musculoskeletal areas that she points to. Okay, so this is what you have to do in order to do the physical examination of the breast. Okay, if anyone wants to practice on this, you can feel here there are several lumps here and there. Okay, of course they are not, I would say it is 30% close to the real lumps. Okay, when you feel on the real patients and real breast, it will be different. The rubber texture and feeling is different. Okay, but this is the best. It is aimed to teach you the steps of the exam. Okay, if you, that's the point.
Okay.
So after we finish, we of course we have to thank the patient. We covered her up, and then we document what we have seen. The way to document the lumps, usually we make a drawing of both breasts. I'm sure you have seen that in the hospital notes. You document the if it is a mass, solid mass, we make it dashed. If it is a cyst, we just leave it blank. And if there is any lymph nodes also, we can do that. A very simple drawing. I'm sure every one of you can do that. Okay? Any questions?
Yes.
Yeah.
How do we measure the size of the lump?
With the measuring tape from one border to another. If it is circular, if it is spherical, it will have same diameter. If it is oval or rectangular, it will have two different dimensions. So you take the biggest dimension in other direction. Okay. Yeah. Anything else? Any questions here? Shall we? Yes, I said examine the thorax. Thorax means examining the respiratory system. Okay? Yeah. Of course, we have to ask it. We have to observe the chest expansion. We have to check the breathing sounds, the vocal parameters, the tactile parameters, okay? And also to do the percussion, to confirm there is a fluid collection which will be done, okay, on percussion. So you do the routine 4 steps of respiratory. Any other questions? Yes? Okay, cervical lymph nodes are not relevant to the breast pathologies. Only if the supraclavicular, and in fact, even the supraclavicular are not considered regional lymph nodes. They are considered distant, okay, distant lymph nodes. So they are treated like distant metastasis. If there is enlargement in the supraclavicular lymph nodes, this will be M1. It will not be labeled under N, because the N for nodal status, either N0, no palpable lymph node, or N1, which means that the lumps are 2 up to 3, but still mobile and not matted together or fixed to the deeper tissues, or N2, when they are fixed to the underlying or the axillary loose areolar tissue, okay, and matted together. But supraclavicular lymph nodes, if it is palpated, this is regarded as M1. M1. Okay? Any other question?
About the axilla, do we need to do both sides on the right side, or
we should.
Can go?
We should.
So the other side.
Usually, the other side, you'll have to go to the other side. Or if the patient is turned to sit by the side of the bed, which is better really, you can have easily access to both axilla. Yeah? Usually we focus on the side because very extremely rare to have a breast cancer in one side and gives findings in the other axilla. Okay? Extremely rare. All right? Of course, there are other lymph nodes which we cannot assess, unfortunately. They are located behind the sternum. So there is an artery on either side, on either edge of the sternum, behind the sternum. It is called internal mammary artery. Internal mammary artery, there is around it lymph nodes, and these lymph nodes receive drainage from the medial part of the breast. So the way to assess them is not clinically, because they cannot be palpated. We can only assess them by a CT scan of the thorax. Then we see enlargement behind, nodular enlargement behind the sternum. Okay? Any questions?
Should we do digital corrector after abdominal examination?
Digital? No. I don't think it's relevant here. Usually the rectal findings are sought in case of abdominal pathology. Okay? Any other question? Any questions? Something I should say about if the patient has a nipple discharge. If you come closer, you will see that there are multiple pits on the mannequin. This refers to the ducts, the opening of the ducts, because the breast does not have a single duct opening. It has about 6 to 8, and maybe even more, of duct opening. So when the patient, if the patient complaint is a nipple discharge, number one, I have to see if this is unilateral or bilateral. Number two is I have to see whether the discharge is coming from a single duct or multiple ducts. Number three, I'll have to see, and maybe after we demonstrate the discharge, if there is no discharge at the time of the examination, we can ask the patient herself to demonstrate, because she knows if she compress a particular area, the discharge will occur. She knows better than us. Then we dab it on a piece of white swab, okay? And then we see the color, whether it is yellow, green, dark, blood, okay, or a pus. All these things can become visible. All right? So most pathologic discharges will be unilateral and from a single duct, and it's a blood. This is the most serious discharge. If it is bilateral and serous yellowish, this could be associated with fibroadenosis of the breast. It could be sometimes some physiologic discharge which has no pathologic significance. But the single duct and unilateral is more serious than the bilateral and multiple duct discharge. Okay? These are the things. Okay? Any questions? Any questions? Okay. Now we have felt a lump here. We are going to, we have done the history taking, the physical examination. After that, we come to do the second step in our assessment. So the first step is clinical. The second will be imaging. Okay, imaging. A word about the imaging. We have two types of imaging that we apply for the breast. Ultrasound of the breast and mammogram. Okay, and mammogram. Mammogram is an X-ray of the breast. Now, any lady who is younger than 35, we do for her ultrasound. We don't do mammogram, because the breast tissue density will not show the lumps on X-ray, because the whole breast is dense and the lump itself is dense, so there is no differences in density. While the older ladies, especially those after menopause, the breast gland is atrophic and most of the breast tissue is now full of fatty tissue, adipose tissue. And the fat on X-ray looks black. So when there is a tissue lump developing there, it will appear as white, dense area. So this is why we say that mammogram is not useful imaging in young ladies who are younger than 35. Mammogram is useful for those who are 35 and above. The older the lady, the better, the higher the sensitivity of the mammogram. Now, you may ask me, do we need to do also ultrasound for the older group, age group? The answer is yes. So we combine both imaging modalities in order to increase our information about the lump. Okay, increase our information, because with the ultrasound, you can assess the blood supply with the Doppler inside the lump, how much blood flow is inside the lump. Okay, you can see the capsule, you can see the the rest of the breast gland, also scan it. You can see the duct system more. So ultrasound and mammogram are used for the older patients. After we do this, then we decide if this lump needs a biopsy. Okay? So let's assume that this lady, since she is 56, we have found a lump, and this lump appears suspicious to be malignant. Okay, confirmed. We're going to do a needle biopsy. Needle biopsy is done by both the surgeons and the radiologist. When the lump can be felt and can be grasped by the surgeon hand, we can do it by free hand. When the lump is deep, cannot be, cannot control it, then we ask the radiologist to do it under guidance of ultrasound. So he will put the probe, he will see how deep is the lump, and then he directs the needle, and he will see the needle penetrating the lump, and then he take the tissue. Okay? So let's go now and do